we had some good conversations, and I was wondering maybe Devinder and Samia, we can kind of get into a few more areas, but also grab the audience. So first off, what are the unmet needs in vitiligo? What do you guys think have to be challenged? So maybe Devinder, you can start off and give us an idea, and then Samia. So you just gave this presentation, so Devinder, where do you think are the holes? Where do we have to go?
Yes, Professor Samia has given a good hope, we have such a good molecules coming up. But when we think of unmet needs, probably most of the time when we have a discussion, someone come up, is there for periungual lesions or acral lesions? So how effective such kind of therapy would be repigmenting a acral patch? So that is, a test of a new drug. Probably if some molecule can cause a repigmentation in the acral area, so that is considered as one of the potentially a sort of an ideal therapy for vitiligo, because most of therapy will work over face and other hairy body areas. We know many treatment options, but we only look at certain areas devoid of black hairs, like leukotrichic patches. So probably those kind of molecule which can have that kind of potential, and still is an unmet need probably to my mind.
Well, of course, we are all in need to find a solution for the treatment of the resistant cases, the resistant areas, the anatomically resistant sites. Until now, all the emerging therapies are attacking the immune pathogenesis pathways, but we do not have, maybe the last, you presented work about the effect of fibroblasts in the acral sites, and we also did a lot of studies about the acral areas. They have lots of differences, but we don't know if these differences are a reflection of the absence of the melanocyte stem cells and the hair follicles, because they carry the stem cells for all the epidermis around. Are these secondary or they are primary? And maybe we can, at the time, we can attack these primary defects in particular.
So a patient walks into your office after hearing Samia's lectures and talk about the pathophysiology, and you walk in and you say, okay, well, we can try this for 10 months, we can try this for 10 months, and we can try this, and we can still find out none of it works. Is there anybody in this audience that can help us with some outcome measures or maybe shared decision making? Any outcome experts here? Anybody with some ideas on how to improve outcome measures? Khalid Azadeen, where's he at? Oh, Khalid disappeared. Ooh, that's gonna be fun. How about Thierry Passerone? Is he in the audience?
Yeah.
Thierry, you had an article on shared decision making and how to make decisions. Can you give us some insights? How do we make these decisions? And we'll get him a microphone. He's the handsome French dude on the corner over there. So that's a question I want to ask you. How do we get to the point where we pick the right treatment for the right patient at the right time?
Thank you very much. I really think that it's crucial to put the patient at the decision of the treatment, because it depends on what the patient wants. Because first we have to explain what are the possibilities, but also as all of you were talking, it's very important to say, oh, it is active, so we have to stop it or not. Do you want to stop the spreading? Do you want me to depigment when it's widespread vitiligo? And to explain also the expectation, because as you really mentioned, it's very difficult to repigment some areas such as on the end, but on the other end, on the face, it's much easier. So it's very important to explain what are the current treatments, how long does it take, because even the new treatment, we're going to talk about it in a few minutes, but they need 6 to 24 months to achieve those results. So it's really, really important to explain this with the patient, and after, with the patient, saying, okay, this is what I would like to do with the current treatment. So there is with Raleigh, we made these files, very easy for the patients to understand, and at the end, this is the patient who decide what we want to do. If I have the microphone, so if I just want to add one point on the treatment. There was two things that is always said, and I would like to try to correct. First, for alpha melanocyte, it is potentially interesting, but for dark skin individuals, but it's not a treatment that will enhance the differentiation of melanocyte stem cells. There is no MC1R on the melanocyte stem cells, so alpha melanocyte won't work on this. That's the reason why it's mandatory to use it combined with UV. And the second part is that it is true that on some areas, such as the extremities on the fingers, there is no hair follicle. But it's well demonstrated too that there are some melanocyte stem cells outside the hair follicle, in the sebaceous gland, in the glabus dermal skin. And it's more difficult to differentiate those melanocyte stem cells, but they are there. So there are some ways, there are antagonists, there are other ways, but there are some possibilities to enhance this repigmentation. And just to finish, I really think, like Davinder, that fibroblast is clearly doing a role, not only in the depigmentation part, but also in the repigmentation part.
Wow, really good point about the M1CR receptor and the stem cells. Thank you. And there's a nice article that Dr. Passeron wrote about shared decision making, so that has to be part of the process. Okay, so a topic near and dear to my heart, outcome measures. VASI or VES? Pigmentation or digital imaging? What do you guys like better? What's your favorite outcome measure? And where can we improve?
Yeah. So yes, still I think the VASI is a gold standard. I mean, we have so many other coming up, but to my mind, as of now, the VASI is still the gold standard. There are some scope for improving, like VASI is also a very strong, which can detect a very minor change as well. So there some modification as your group has done even on the VASI by taking the 10% scale. So that kind of scale, so with some further computerized scale would be, I think, which can exactly detect even the minor change can be there. But from practical purposes, as of now, VASI still remains the gold standard.
Samia, do you agree with that? And then
Well, I think what we need is that we have a good objective measure to measure the changes of the outcomes. So this depends on how the investigator or researcher feels friendly more with the technique itself. Maybe I like to use the VASI, maybe you like to use the VES. I mean, so what's important is so long they are both validated scores, so we can choose what is more convenient for using. Some of our residents like to use the VES, and others like to use the VASI. They learn both of them well, and they know how to use them, but so long they can do one of them efficiently, it's enough. That's what I think, because both of them are working very well.
Well, thank you. You're always welcome to my house for dinner now. But what about measures of patient satisfaction? Isn't that the most important thing? Pigmentation isn't why we're treating patients. It's because of the measure. So do you have any outcome measures that you guys like that you think that we need to work on? Anybody have a favorite outcome measure? Dr. Maya?
Sir, when we listen about 50% pigmentation, 70% pigmentation, it's okay from pharmaceutical point of view. But for patient, if he has 4 centimeter patch on his cheek or 1 centimeter patch on his cheek, he is labeled as vitiligo. So unless there is 100% cure and very effective treatment, well, I don't know about the satisfaction of the patient.
Yeah.
Any small patch or big patch doesn't matter. There is a patch, so he has vitiligo.
So would another statistic, maybe saying 1/3 of people get all the color back, would that be helpful for patients to hear that statistic? Like what % get all the color back, like as a binary output?
Yeah, that cosmetic may help him.
Okay.
Yeah.
Okay. Let's ask the audience, what are you most optimistic for in research for vitiligo? Where do you think is going to be the big jump? What are you excited about? Nobody's excited. We did not do a very good job. We put them to sleep. Okay, I'm going to call on somebody. Dr. Kanika. Thank you for being courageous. You must be from Delhi. The courageous side of India.
I always find it interesting to hear about the new innovations and the new drugs that are coming up. But as the patient representative here, she just said that it's important to understand how a patient feels about the disease and as to how much they can accept the disease, because we know that in a large proportion of our patients, we cannot offer them cure. We cannot offer them 100% repigmentation. So I really feel that we should work upon the psychosocial impact of the disease and how we can reduce it with psychological interventions, with yoga, with meditation, with breathing. So all these things, I think, would probably increase the acceptance of the patient towards their disease and also improve their confidence and the way they deal with it in the outside world.
And also maybe the stigma, maybe
Yes.
treat society too.
Yes.
So we'll have Marwa and then our colleague over here go next.
Well, actually, there is a dream. Not maybe it's not now of primary importance, but it's a dream, and I would dream of having treating the acral vitiligo, especially of the hands and orally, because these are the most seen of the vitiligo patient, and they are the most difficult to treat. So this is the most the difficult to treat areas should be should have a solution.
Great. Our colleague over here, please.
Actually, your question was where we are looking forward, which field to develop more, work more. I would say genetic engineering also one thing which we have to look forward and make it more, though it's not working, but in future we can look forward one. And second to how to basically approach the patient, because your patients, if maximum patients are happy, so the patient's ambience is very important. So it is one of the most important psychological impact on patients. When he walk into the clinic, he see other patients, and then he get the confidence before he enter to you. So then you can of course counsel, but before that mostly patient get their opinion before entering to your chamber.
Well, I can tell you, coming from Detroit, Stephen, who's here, he has lifted up so many people's perceptions of himself just through his conversation. So I agree, having patients talk to other people with it helps them. Oh, great. Our wonderful scientist, our fibroblast.
And keratinocytes.
Yeah. And keratinocytes, sorry.
Yeah, so what I think would be very important for patients research-wise is why vitiligo spreads and the Kubner phenomena, if we could solve that. Because when a patient comes to a doctor, the first question is, will it spread or not? And can we also do something about the relapse? Can we predict, first of all, and are there molecular markers which can predict that, this lesion will relapse or not? That will provide great relief to the patient that, this will not relapse. Those kind of markers are necessary.
So stability and relapse. Okay,
Yes.
Great. And we got one more colleague over there. Oh, from Chandigarh. Come up, please. Do you know this guy, Dr. Prasad? Yes. A little shady.
Yes, sir. Myself and sir, we take care of the pigmented clinic at PGI. So that's what, as I was discussing with you, like the stability process, like if suppose a person has been having a stable disease for past 4 years, suddenly develops one small lesion in a month, and then if you see the VIDA becomes VIDA 4+. So are we to give the patient a high dose of, for example, OMPs or any immunosuppressants? So we need to do a long-term study, follow that patient up before we say he's actually in a very active state of vitiligo sort of a thing. So I wanted to see on the activity, and partly what the other doctor, the scientist wanted, when can we predict a relapse? See, because most of the time, childhood vitiligo, we give OMP, it stabilizes. You leave around 6 to 8 months, the mother usually comes back and says, there is slight increase in the depigmentation of the old depigmented lesions and things like that. So is there somewhere we can say like these are the patients who are going to throw back the lesions, so that like how the psoriasis has a combination treatment, right? They start with methotrexate, then they finish it, then they go into the retinoids, or then go into POA. So like that sort of a rotational therapy, should it be there in for vitiligo also? That's what it
Great.
is.
Some great ideas. So, we're going to...
I have an ambition.
Oh, go ahead.
I have an ambition, yes.
Sure.
Anyway, I wish that all the treatments that we are having now can control the progress of the disease so that we don't reach the irreversible lesions, because we have those hand lesions that we are all commenting about, because they started as small ones and they continue to grow till they can involve even the whole hand. So if we can use all our weapons, all the emerging treatments, so that we can stop the disease as early as possible, so that those areas do not develop, until we can find a stem cell or something that we can replace the stem cell deficiency on the hands. I wish that we can use these medications to reach this goal.
Great.
Yes.
Devinder, do you have any final comments?
Yeah, so I agree with Professor Samia, so same view.
Well, it's...
Dr. Hamzavi.
Please, touch on it.
I'm Dr. Ng from Taiwan. So what we found in our clinic is a lot of patients get really stressful, like what all the professors say here. They are very stressful when it's actually going to recur, and sooner or later, even if it's a very tiny lesion at the initial stage, it's going to spread. And in lighter skin tone, it's actually less visible at early stage. So I think there's a really unmet need in a more safer medications. Of course, there's JAKs here, but if you look at the development in psoriasis or in atopic dermatitis, really it ends up with biologics, because it bypasses the metabolism from liver or kidney metabolites, just like we do with the conventional DMARDs, and JAKs also do have those problems as well. So I think there's for futures, if long-term controls, I think the development of biologics, it will be a very promising thing to do in vitiligo, and to prevent them from spreading. Especially, it's an irreversible disease if it's in an advanced stage of destructions. So I would often discuss it with my rheumatology colleagues. They are quite curious about what we are thinking about vitiligo, because we only treat them in a very active stage, but whereas according to the consensus, we just stop the treatment and put them on topicals or phototherapy, which is very stressful to the patients because of the compliance. Not many of them were able to get phototherapy 3 times or 2 times or 1 time per week. And topicals, well, if it's not visible at early stage and active stage, how are you going to apply it on the whole body surface area? So that is what we are encountering in the clinical practice. And when it comes back again, and a lot of my patient does, I mean, the recurrence rate is really high. So probably we need a really safe, targeted biologics in the future. That's what we are hoping for in the future of vitiligo treatment. Thank you.
So safety and relapse. We're going to take one more comment from our colleague in Egypt, and then we'll finish up. So please, at the end.
The problem I'm seeing in the last few years of vitiligo, that we have more patients every year. I think this is something to do with the lifestyle we are living. So we have very limited advice to give to our patients concerning what's next to treatment. How do they live? How to what things that they should avoid to do to stop reactivating the disease. Like you can tell your patient, stop having stress, emotional stress, and this may activate your lesions, your disease, but there is a lot of other things. For instance, in my country, in my clinic in Upper Egypt, farmers and people who are working in the sun of skin type 3 and 4 for long hours in the hot sun, they have more incidence in vitiligo than other people. So I hope that we can at one time tell our patients what to eat, what not to eat, at what time they can see the sun and at what times they have to avoid the sun. If you have a patient treating him from acral vitiligo and he's working with chemicals, what kind of chemicals he should avoid to keep his melanocytes survive. So my hope is not only the drugs. We have to understand what are the triggering factors there are some papers speaking about the gluten and the white flour in depigmentation of skin and the activity of vitiligo. So this is my concern. I need to give my patients some advice how to live in a safe way that cannot trigger the disease to reactivate.
Great. Fundamental mechanisms, diet, environmental triggers. Well, thank you for that aspirational goal. I want to thank Pfizer for the support of this program and all of their team who's in the back for the creation of the slides. I want to thank my colleagues, Dr. Simia Asmat and Devendra Prasad, for this wonderful program. And I wanted to thank you for staying involved and engaged and taking us to the next level. Scientists, you have a lot of work to do. So thank you so much.